Hi, I'm Dr. Rivera Camacho. I am an emergency medicine physician trained in ultrasound and global health. I'm a faculty member of the emergency medicine residency at the Jackson Memorial Hospital and also voluntary assistant professor at the University of Miami Miller School of Medicine. Today, we're going to discuss point of care ultrasound. First, I'm going to tell you a little about me and why I love emergency medicine. I love its diversity, not only in patient population and in pathology, but also the procedures we perform, including ultrasound, of course. I like teaching ultrasound in low resource settings and the work-life balance. As part of our learning objectives, after participating in the session, attendees should be able to explain the physics of the ultrasound machine. Attendees should be able to use the appropriate probe for different ultrasound applications. Attendees should be able to recall the views of the EFAST. Attendees should be able to identify normal anatomic structures in the EFAST and should be able to recognize pathology in the EFAST. So we're going to get started with sound physics. We all love physics, right? So let's remember from biology class that echolocating animals emit sound waves out into the environment and listen for echoes of those calls to locate and identify objects. This concept was used by scientists as the basis for later studies for Doppler and ultrasound. So now let's remember from physics class that sound has a range of frequencies. We have infrasounds, which humans cannot hear. We have acoustic sound, which humans can hear. And anything above 20 kilohertz is considered ultrasound. So some animals, such as bats, can hear ultrasound. However, the frequencies used for medical ultrasound are significantly higher compared to acoustic frequencies. So humans are unable to hear them. At the bottom panel, we can appreciate the relationship between the frequencies and the sound waves. Infrasound has a lower frequency and ultrasound has a higher frequency. So let's review some definitions. The period is the time that it takes to complete a cycle, and the wavelength is the distance that sound travels in one period. So the frequency is the number of cycles per second, and it has an inverse relationship with the wavelength. So let's compare the top panel with the lower panel. The top panel has a shorter cycle. This means that one wave travels for a short distance. Think a small person that has short steps. So I need more steps or a higher frequency to arrive to the same location. In turn, in the lower panel, has a longer cycle. So this wave can travel for a longer distance. Think a tall person that has longer steps. So I need less steps or a lower frequency to arrive to the same location. So now that we have reviewed sound physics, we're going to talk about how the ultrasound machine works. Transducers today are manufactured with crystals that are housed within a plastic probe assembly. A computer sends an electric signal to these crystals, which in turn creates a mechanical sound wave in form of vibrations to be produced. This mechanical sound wave enters the body where it encounters different types of tissue. The tissue reflects sound based on their degree of density and elasticity, which in turn causes the returning sound waves to vibrate the crystals in the probe when they return. And this in turn causes an electric signal to be produced, which is then transmitted back to the computer. So depending upon the length of time and the strength of those returning sound signals, an image is produced. So in order to produce an adequate image, we need to select the appropriate probe. Each probe has different properties. We're going to first start with a linear probe, which produces a high frequency sound wave, which means it can travel for short distances. This makes it a high resolution probe that is good for superficial structures such as the skin, the vasculature, eyes, musculoskeletal, and pediatric abdomen. The image on the right is an eye. The depth is set at 4 centimeters, so it is superficial. The following probe is a curvilinear probe, which produces low frequency sound waves, which means that it can travel for long distances. This makes it a lower resolution probe that is good for deep structures, such as the abdomen and the thorax. The image on the right is the left flank evaluating for free fluid in the spleen and the kidney on an EFAS exam. The depth is set at 15 centimeters. So you can see that it can reach more depth compared to the linear probe. The next probe is the phased array probe. The phased array probe produces a low frequency sound wave, which means it can travel for long distances. This makes it a low resolution probe that is good for deep structures such as the heart and the lungs. However, it also has a small footprint and a high temporal resolution, which is important when looking at structures that move fast, such as the valves inside of the heart. This image, we can appreciate a great resolution of that mitral valve as it opens and closes. The following probe is a 3-in-1 probe. This probe has a semiconductor chip instead of crystals. It has adjustable frequency based on the exam type, and it has a variable resolution and depth. So you can perform all exam types. In the image in the center, we can see the femoral vessels on a linear setting. In the image on the right, we can see the phased array setting on a cardiac exam. So once we selected the probe for the structure of interest, we have to interpret the image. So ultrasound images are described in terms of intensity of sound waves reflection back to the probe. So an organ that does not allow any sound wave to pass through it reflects all the ways back to the probe. This is known as hyperechoic. This includes bone, air, and fascia. An organ that allows some transmission of sound waves to pass through them and reflects some sound waves back to the probe is called isoechoic, such as the spleen. Organs that appear darker or hypoechoic allow more sound transmission than reflection, such as the kidney. And structures that allow complete transmission through them, that is, does not reflect any sound wave back, is called anechoic, such as fluid like blood or urine. So there are several modes in which we can evaluate images acquired. The first one is B mode or 2D mode, also known as brightness mode. This provides structural information utilizing different shades of gray or different brightness in a two-dimensional image. The brightness is determined by the amplitude of returning echoes. So this image is an image of a 13-week-old fetus in B mode. At the bottom of the image, we can see that the machine tells us which mode we're using, so 2D mode. M mode, also called motion mode, captures returning echoes in only one line of the B mode image displayed over time. Movement of structures positioned in that line can now be visualized. Often, M mode and B mode are displayed together in real time on the ultrasound monitor. M mode at the inferior portion of the image, and B mode at the superior portion of the image. In this image, the M mode captures the movement of a particular part of the heart across the dotted line. And each wave represents a structure such as soft tissue. For example, over here, which is a soft tissue here. This anechoic area is a pericardial effusion that corresponds to this area here. And then we have the right ventricular free wall, which corresponds to this line. Later, we have a mitral valve over here that corresponds to this wave over here. So we can see how the lower pane is M mode and the higher pane is 2D or brightness mode. Lastly, we have the Doppler modes, which examine the characteristics of direction and speed of tissue motion and blood flow and presented in either audible, color, or spectral displays. Today, we're going to discuss color Doppler specifically, which is also called color flow. It is used to show blood flow or tissue motion in a selected two-dimensional area. Direction and velocity of tissue motion and blood flow are color-coded and superimposed on the corresponding B mode image. Typically, red depicts movement towards the transducer and blue depicts movement away from the transducer. However, this does not always mean that red is an artery and blue is a vein. In addition, the scale can also be manually reversed, such as in this example. Lastly, let's review the buttons, also known as the knobs. First, we're going to turn on the power. Then we need to input the patient's information, such as the name, the date of birth, and the indication for the exam. After that, we're going to select a mode. Typically, the machines will default to B mode or 2D. You can also change it to M mode or Doppler. Then we are going to adjust the depth and the gain. And after we have the image that we need, we can freeze the image to save an image, still, or video clip. So differently than radiologic diagnostic ultrasound, physicians that perform point-of-care ultrasound are responsible not only for image acquisition, but also for image interpretation and the clinical correlation. So these are several applications that we can perform with point-of-care ultrasound. This lecture will discuss the basics of the EFAST exam. So the EFAST stands for Extended Focused Assessment with Sonography and Trauma. The main indications are blunt trauma and hypotension, although there are other non-trauma indications such as looking for free fluid on a pregnant female to rule in an ectopic pregnancy, or looking for free fluid on a non-pregnant female that's hypotensive to look for a cystic rupture of an ovarian cyst. We can also evaluate for ascites. There are some limitations to this study, such as you needed around 300 mL of free fluid to have a positive FAST. It's not good to rule out retroperitoneal hemorrhage or solid organ trauma, and it does not rule out hollow viscous injury either. So we can see that the sensitivities are not great, but it has great specificities. So it does not rule out free fluid, but it is useful to rule it in. That is helpful when there is a patient that's unstable, and it helps expedite surgical management and forego additional imaging such as CT scan. And it can also expedite transferring a patient to a trauma center when the patient is still stable. So the EFAST interrogates three main boxes. We have the pleural space in the thorax, the pericardial space in the heart, and the peritoneal cavity in the abdomen. The views of the EFAST are the right upper quadrant, the left upper quadrant, the pelvic, both sagittal and transverse views, the subcostal view, and the thorax bilaterally. The right upper quadrant view is obtained at the right mid-axillary line with the indicator towards the patient's head. This is a coronal cut. The potential spaces evaluated are above the diaphragm, below the diaphragm, Morrison's pouch, and the caudal tip of the liver, which is the most sensitive view of the EFAST. Then we have the left upper quadrant view, which is obtained at the posterior axillary line with the indicator towards the patient's head. The views obtained are above the diaphragm, below the diaphragm, the splenorenal space, and the inferior pole of the kidney. On this view, the area between the diaphragm and the spleen is the most sensitive view of the left upper quadrant. This is also a coronal cut. Then we have the pelvic view. We're going to start with the sagittal view. The pelvic view uses the full bladder as an acoustic window. An empty bladder makes this view indeterminate. For the sagittal view, the probe is placed at the suprapubic area with the indicator towards the patient's head. In the biologically male pelvis, we interrogate the retrovesical space, which is the area superior and deep to the bladder. In the biologically female pelvis, we interrogate the rectouterine space, also known as the pouch of Douglas. This area is deep to the uterus. Free fluid can also be seen in the vesicouterine space, although at larger amounts, and this is usually a later finding. To obtain the transverse view, the probe is placed on the suprapubic area with the indicator towards the patient's right. In the biologically male pelvis, we interrogate the retrovesical space, which appears lateral and superior to the bladder. The seminal vesicles are deep to the bladder. In the biologically female pelvis, we interrogate the rectouterine space, also known as the pouch of Douglas. This area is deep to the uterus. The subcostal view is obtained by placing the probe inferior to the xiphoid process, flattening the probe against the abdomen with the indicator towards the patient's right. We evaluate the pericardium for free fluid. That is the pericardial sac. Lastly, the thoracic views are obtained with the probe in the anterior chest wall at the mid-clavicular line with the indicator towards the patient's head. The image on the right demonstrates the landmarks of the chest wall. First, we have the skin, then we have the subcutaneous tissue and the pectoral muscle. Deep to that, we have the intercostal muscles and the ribs. The pleural line is deep to the ribs. When there is a normally expanded lung, there will be lung sliding, which appears like ants on a log, such like this image. So this is a normal and expanded lung. This is a parietal and visceral pleura sliding against each other. When there is a pneumothorax, there will be absence of lung slidings. Now we're going to discuss the study that was published in 2020 at BMC Health Services Research by Ross, Kalia, Chang, and Lee, titled The Influence of Patient Race in the Use of Diagnostic Imaging in United States Emergency Departments, data from the National Hospital Ambulatory Medical Care Survey. The study included ED patients from hospitals across all 50 US states and Washington, D.C., including urban and rural hospitals, regional trauma centers, and smaller non-trauma sites. It excluded federal, military, and VA facilities. There was a random 4-week survey period between 2006 and 2016. In terms of results, using weighted data, an average of 131.5 million patient encounters were included each year for the 11-year study period. Imaging was used at 46% of all visits. Although this varies significantly by patient race and ethnicity, with white patients receiving medical imaging at 49% of visits and patients of color at 41% of visits. This was statistically significant with a p less than 0.001%. This effect persisted in the control regression model across all imaging modalities except ultrasound, which is very important, noting that ultrasound can help the patients get imaging, particularly when there might be still some implicit bias in terms of acquiring imaging. Lastly, we're going to finish with a case. This is a 27-year-old female who presented to the emergency department after being struck by another vehicle while riding her bicycle. She has signs of trauma to the torso and abdomen. Her vital signs are concerning for shock. So she was taken to the most close emergency department, and we're going to select the appropriate probe to perform a FAST exam. We're going to use a linear probe for the thoracic exam and either the curvilinear or phase array probe for the abdomen and heart. The view of the right upper quadrant shows an anechoic area of free fluid at the caudal tip of the liver, which is the most sensitive area for free fluid in the entire FAST exam. In the left upper quadrant view, we see an anechoic area between the diaphragm and the spleen, and also between the kidney and the spleen. That is concerning also for free fluid. The following image, the first one on the left, is a sagittal view of the female pelvis. There is free fluid in the rectouterine space, also known as the pouch of Douglas. in an untransverse area of the pelvis. There's also an anechoic area, free fluid, deep to the uterus. Her subcostal view has a pericardial effusion, which is noted over here. Her right thorax, the pleural line deep to the ribs, do not show lung sliding, concerning for pneumothorax. The left thorax has lung sliding. So this patient ultimately had a chest tube placed, received IV fluids, and received a blood transfusion. The surgeons took her emergently to the operating room. So in summary, point of care ultrasound is performed, interpreted, and clinically correlated by the physician at the bedside. EFAST is useful to rule in free fluid in 3 areas: the thorax, the heart, and the abdomen. Also useful to evaluate for pneumothorax. Patients of color have been found to undergo imaging less frequently than white patients, except for ultrasound. Here are some references, and additionally, some free open access medical education resources. Thank you for your attention. Have a great day.